Right. Okay. Correct. All right. So I'll share this. So let's do the ischemic heart disease and hypertension one next. All right. ඒක මට අනේ පළවෙනි පාර ඒක share කරන්න අමතක වුණා because it was named as something else and I forgot. I hope you have done it. ඒක හම්බුණා නේද ඔක්කොලට?
Okay.
Right. So Supun for does smoking cessation, I guess. That I will have to check if there are any trials out there. As far as I can remember, no is the answer for that, Supun. But I'll have to check the literature and see. Right. Okay. Right. Now, this first MCQ focuses on the risk factors for ischemic heart disease. Right. And this is hopefully an easy sort of thing to talk about. Of these 5 statements, I'll start with statement number 3 right at the start. Ischemic heart disease is not exclusively due to obstructive coronary artery disease. Right? It is not exclusively due to obstructive coronary artery disease. Because that is common sense. That is, even if you have absolutely normal coronaries, if the demand of the heart is increased, they can still have ischemic heart disease. Right? So that is false. Now looking at the risk factors for coronary artery. Again, I'll share this presentation. Next time I will share it before the session so you can make notes on this. Sorry, I forgot to do that today. But this sort of gives you a summary of all the risk factors for coronary artery disease. And this is common sense. Most of these are common sense things. And now we recognize that a lot of okay. So, right. So here what we are seeing is there are certain markers that we now recognize, like for example, CRP, lipoprotein A, fibrinogen, right? Inflammation, right? Inflammatory diseases like rheumatoid arthritis, for example. These are all now being recognized as risk factors for atherosclerosis and ischemic heart disease, right? So just to keep an eye out on that. Apart from the classical risk factors like smoking, diabetes, etc., some of the sort of other unusual things like inflammation, like things like lipoprotein A is a very strong risk factor for ischemic heart disease. Right. So yes. So the first statement is true, and also if you take the lipids, oxidized LDL is very, very atherogenic, right? Oxidized LDL is extremely atherogenic, right? So that is also true, right? And third statement we said is false. Hypothyroidism, I'll talk about the fourth one in a minute. Hypothyroidism, right? Hypothyroidism increases the risk due to several reasons. Partly because it increases your lipids. So hypothyroidism is associated with hypertriglyceridemia and low HDL levels. So it can be related to high triglyceride levels and low HDL levels, right? So that is hypothyroidism. Now, what about acute coronary syndromes and ischemic heart disease in females? Here I have a slide which I have sort of summarized some of the important facts about ischemic heart disease in females. I'm not going to read this for you. It's just as a reference, right? But what is clear is that actually patients, women have more complications secondary to acute coronary syndromes, right, ischemic heart disease related complications are higher in females, right? And probably mortality is slightly higher as well. So I'll just give you a minute to read that. Right. Any questions from that?
Sir, in that one, sir, what's meant by this higher non-STEMI? Is it that women have more?
Yeah, women have higher incidence of non-ST elevation in men. Yeah.
Right. Okay. That's not compared to men, right?
No. Right. Okay. Right. So I think we have covered all the 5 statements in this one. Yeah. Okay. Right. Now, if you look at the pathogenesis of ischemic heart disease, you know that there is a group of people, who have what we call now, again, this changes, is very annoying. Now this is called chronic coronary syndromes, right? Chronic coronary syndromes or chronic stable coronary syndrome. Various things are called, but CCS කියන නම තමයි දැන් පාවිච්චි කරන්නේ, right? Patients with chronic coronary syndromes commonly present with stable angina, right? They present with stable angina. And these patients have a plaque which limits the flow, right? Most of them at least. So they have chronic coronary artery disease or chronic coronary syndromes, CCS, right? Now, when this plaque ruptures, right, when this atherosclerotic plaque ruptures, they develop a thrombus, right, on top of the ruptured plaque. They develop a thrombus on top of the ruptured plaque, and that knocks off the coronary blood flow, right, knocks off the coronary blood flow. And therefore, they develop acute coronary syndromes, right? So that is your sort of main classification of chronic coronary syndromes, where they have stable angina most of the time, versus acute coronary syndromes, where they have a plaque rupture and they develop a thrombus. Right, so that is the main classification. There is another classification of myocardial infarction කියලා වෙනම classification එකක් තියෙනවා, which I won't go a lot into. I will mention it as we go, right? So this is one of the classifications that we currently use for ischemic heart disease. Right. Now, I just told you that patients with chronic coronary syndromes present with angina, right? This angina is stable angina, right? What that means is this comes on when they walk a certain distance, right? And then improves with rest. So that is chronic stable angina. Right, let's go through some of the important clinical features and investigations in a patient with stable angina and chronic coronary syndromes. Number 1, decubitus angina. So decubitus angina is angina when the patient is lying flat, right? Is indicative, sorry, the grammar is wrong there, indicates, right? Indicates severe coronary artery disease. Yes, so this is true, right? So if patients have angina when they lie down, especially nocturnal angina, that actually indicates very severe coronary artery disease. So the first statement is true. Resting ECG is abnormal in 50% of patients presenting with angina, with stable angina. That is again wrong, because whatever changes happen in stable angina happen when the patient exerts, right? So in most of your patients with stable angina, they will have a normal resting ECG, right? They will have a normal resting ECG. So that is false, obviously. Right. Now, before we do the other few MCQs, the other 3 MCQs, I'm going to teach you something. Right. Now, this is the algorithm or the flow chart which is recommended based on current guidelines for investigations of chronic coronary syndromes or stable angina, patients who present with stable angina. Right. So when somebody comes to you with stable angina, right, what you do is, obviously you have to do some basic investigations, right, like a resting ECG, their biochemistry, some people chest x-rays, some people echoes, all of these. So you will consider some basic baseline investigations, right. Then, based on your history, and remember there's a lot bearing on there's a massive amount of weight on the history here. If the history is suggestive, right, with possibly some backing up investigations, like say for example, they have anginal symptoms, they have diabetes, they are smokers, so that's a good history. And then their cholesterol, and you investigate their biochemistry shows an elevated cholesterol, poor glycemic control. So that's a nice history and baseline investigations demonstrating your clinical probability of them having chronic coronary syndromes. That is a clinical probability, right? If they have high clinical probability, we will then, right, high clinical probability, you start them on treatment with anti-anginal medications and other things which we'll talk about in a minute. But you will also do some dynamic testing for ischemia. Dynamic is the word which is important here. Dynamic testing for ischemia, where you put the heart at stress and do tests. So this is when the clinical probability is high, right? So, for example, a patient with diabetes and stable angina symptoms and risk factors, all that is a high clinical probability. So these people, you will do some dynamic testing to prove your diagnosis or confirm your diagnosis. Starting them on medication, yes, but you will consider doing some tests to confirm your diagnosis. So you do dynamic tests. In Sri Lanka, the commonly used dynamic test is an exercise ECG. That is the most commonly used dynamic test. But currently, the world is sort of moving away from exercise ECGs because of certain limitations. And now people recommend a lot of imaging-based dynamic testing. Imaging-based. In this guideline also, they say imaging testing preferred. See, clinical likelihood of obstructive CAD. So testing for ischemia, imaging testing preferred. So things like stress echocardiograms. There is another one called myocardial perfusion scanning, which is a radionucleotide scan. It is available in Sri Lanka, right? Radionucleotide, myocardial perfusion scans, right? There are newer modalities of MRIs, cardiac MRIs that can do dynamic tests. So those sort of imaging investigations are preferred, right? But in Sri Lanka, we don't have a lot of them. So we use exercise ECGs. It's not bad. Even in America, people use a lot of exercise ECGs. But currently where the guidelines are headed are more imaging-based things, because you can see for your own eyes what the perfusion is like during stress, right? So, right. If the diagnostic probability is low, say for example, you have a young guy coming in, no risk factors, the history is also not very suggestive. Having done 2 medical appointments and a prof appointment, you would have seen plenty of these patients coming to the casualty. ECG is normal, they don't have any risk factors. So that sort of patient, they have a low probability of having a significant coronary artery disease. They don't have a high probability. The probability is low. For those people now, what people recommend is coronary CT angiogram. And that has become a nice rule-out test. So if that is normal, you can virtually exclude coronary artery disease. If your coronary CT angiogram is normal. So currently, we have D-dimer wage for pulmonary embolism, right? We'll talk about that later, but I've taught you this before. So coronary CT angiogram is if your diagnostic probability is lower, then you can do a coronary CT angiogram. And that looks quite nice actually. This is an example of what it looks like. And you can see these plaques here, right? So this is a rule out. That make a normal nang, you can exclude it, right? But and you can see plaques. It doesn't necessarily mean that these are significant, but there are plaques. So there is a possibility that this is significant coronary artery disease. And here you can see, these are all stress imaging myocardial perfusion, where you can see the blood flow for your own eye. So these are some of the examples of imaging tests, dynamic tests. Hi. Right. So unfortunately in Sri Lanka, we don't have access to a lot of these investigations, and we end up doing exercise ECGs quite a lot for everybody, right? But if we have the facilities, I think they're trying to establish CT coronary angiograms. It's just like a normal CT scan, little bit of dye, and you look at the coronary. It's not like an invasive angiogram. It's just like a CT scan, like a CT head ekak wage ekak. Has a good negative predictive value for coronary heart disease. So if you do it in a low clinical probability patient, if it's negative, you can confidently exclude it. Right. So unfortunately, we don't have a lot of these things. Exercise ECG is what we have, right? And remember, there are certain contraindications for exercise ECG. ACE is a contraindication, and I have given all the contraindications, and I will send this to you as soon as we finish today's class so that you can go through, right? So these are all contraindications, AS, or etc. The exercise ECG is very difficult to interpret if they have pre-existing ECG abnormalities, like left bundle branch block, for example. Hari amaru එක interpret karanna in that situation. Right. But if you manage to do an exercise ECG, the most important changes are these two. මේ figure එක බලන්න, මෙතන මේ පින්තූරේ බලන්න ළමයි. Here. Right? So the positive ones are horizontal. So during exercise, if you see a horizontal ST depression or a downsloping ST depression, these are your positive responses or positive findings for significant coronary artery disease. Horizontal ST segment depression and downsloping ST segment depression. J point depression when a may wage or upsloping is negative to equivocal. So the most significant findings are horizontal and downsloping ST segment changes. Right. That's an important fact to remember. Right. So exercise ECG, remember, is not currently preferred in the guidelines, but because of resource limitation in Sri Lanka, we use it, right? But it is a good test in most patients. There are contraindications. It is difficult to interpret when there are existing ECG abnormalities, right? That is very clear, right? And then the changes, upward sloping, downsloping and horizontal ST segments are what you look for. CT coronary angiogram has a good negative predictive value, hari. Right. And this is what the CT coronary angiogram looks like. And this is what an imaging dynamic test looks like. Right. Any questions up to now from this?
So this upsloping ST depression, as suggestive of
they are considered equivocal responses. So may or may not be. But clearly, if you see a horizontal or a downsloping, that is positive. Yeah.
Right. Okay, sir.
Okay. Right. Okay. Right. Moving to question number 3, which is now mostly in talking about management. All patients should undergo invasive coronary angiogram. Right. Now, the moment you read that statement, you know that's rubbish. That's absolute rubbish. But when do you do an invasive coronary angiogram? So let me tell you that as well. You do invasive coronary angiogram for chronic coronary syndromes or chronic coronary artery disease for mainly two indications. Invasive arterial puncture, invasive angiogram. Remember, CT angiogram is a completely different thing. It is like just a CT scan, right? Special protocol and CT technique, but it is a CT scan. Invasive coronary angiogram is a completely different thing. Right? So when do you do an invasive coronary angiogram? Chronic coronary artery disease. Number one, when they don't respond to medical management. When they do not respond to medical management. And you think that doing an angiogram might change the management. Say somebody who is 95 years of age, who is on maximal medical management but still symptomatic. Are you going to do an angiogram on that person? No, you're not. Because revascularization is futile. So remember, so number one indication, they should have symptoms. They are on maximal medical therapy, no response, continuing to be symptomatic. But you have to have some confidence that it will change the management. So you don't do it in patients who have kidney failure and liver failure, who have futile. Management. Right. That is one indication. Number two indication is, now you do all these dynamic tests. Based on the findings of the dynamic tests, you can classify patients as high risk. High risk, these patients are likely to get a MI or likely to die. So based on, say, there are certain, there are criteria. On the XICCG, if you see this and this, that's high risk. On the myocardial perfusion scan, if you see this and this, that's high risk. They are likely to have an MI. They're likely to die, right? Those sort of people, we do an invasive angiogram. Right? So this sort of people, we will do an invasive angiogram. So either they are on maximal medical therapy and they don't respond, or they have high risk features on their dynamic tests and clinical sort of history, right? High risk features. Those sort of people, we will do invasive angiograms. What are the high risk features? You don't need to know. If you are interested, ඕන පොතක තියෙනවා, ඕන guideline එක තියෙනවා, ලොකු ලයිස්තුවක් එක. ඉතින් මතක තියාගන්න බෑ. XICCG එකේ මේ දේවල් තියෙනවා. If the radionuclide scans, myocardial perfusion scans, if you find these features, that's high risk කියලා, right? Echo එකේ ejection fraction එක low නම්, that is high risk. ඒ වගේ. So those sort of criteria, there are list of criteria. Right. Okay. So that is false. Now remember that in stable angina, probably only thing that has some sort of outcome benefit or improvement of outcomes, say preventing MIs, that sort of thing, is aspirin and a statin, right? That is the only thing that has sort of mortality or outcome-based benefit. None of the anti-anginal medications have mortality benefit. Nitrates, beta blockers, calcium channel blockers, none of those have mortality benefit. Right. And medical management is successful in most patients with stable angina. There is no doubt. Medical management is, most patients respond very nicely to medical management. They respond very, very nicely to medical management. Statement 4 is easy. I don't even have to talk about that, right? Yeah. Okay. This is just for your reference on how we use anti-anginal medications, right? I'm not going to go into this in detail, but remember, standard first-line therapies are beta blockers and calcium channel blockers. Right. Okay. So any questions about all of this that I have described? I remember somebody telling me in the appointment that this was a bit unclear, this chronic coronary syndromes. Are there any questions about this?
Sir, could you just repeat what are the drugs which are started in all patients?
So aspirin, statin, and then beta blocker or calcium channel blocker. Yeah. Anti-angina and nitrates also, obviously.
Right. ACE inhibitors don't have a place.
ACE inhibitors, there is some evidence that it might have a benefit, but you have to be careful with the blood pressure. So if the blood pressure is not high, it's going to drop the blood pressure and cause problems more than the benefit. So that is a bit of a gray area there. Yeah. But potentially, if they have, say, structural changes in the heart, it might have a benefit. Yes, because we talked about this in the previous discussion on heart failure. So if they have some structural changes, changes, it might have a benefit. Yes. Right. Okay. Right. Now, this is a very special MCQ. So, in chronic coronary syndromes, Nipun, there is no indication for dual antiplatelet. Chronic kevala. I'll talk about acute coronary syndromes in a minute. Chronic kevala, there is no need to give dual antiplatelets. There is no indication for dual antiplatelets. So, no, none of these anti-anginal. Ivabradine is also an anti-anginal. Ranolazine is another anti-anginal. None of those have mortality benefit angina. Ivabradine has a different story in heart failure, but not in angina. So none of these anti-anginals have any mortality benefit. Right. Okay. Now this is a special MCQ. Samahalata me wage amutu e wahano Prince metals angina. So in the next slide, I have given you a small comparison between Prince metal angina and also the sort of classical ischemic angina. Right. So Prince metal angina is due to coronary vasospasm, right? That is the reason, or that is the cause of Prince metal angina. Right. We'll come back to this table. Right. I put a balandoko. Sorry. Sorry, I'm putting a message. Right. Okay. Right. So Prince metal angina is common in females, right? And is due to coronary vasospasm. And it has a very sort of a periodic history, a cyclical history occurs at rest and ude pandara dekata wage thamai ogenne. So it has a sort of a cyclical history. Occurs at rest early in the morning, cyclical. Hamadama wage oka rata enawa wage. Sort of a cyclical history at a specific time. Right? And is due to coronary vasospasm. If you are able to record an ECG during an episode, you will see transient ST elevations. Transient ST elevations. Right? And that is what you classically see. Right? And calcium channel blockers are used in the treatment, but they do respond to nitrates as well. The pain responds to nitrates as well. Right. So I have covered all this here. So females like a common coronary vasospasm is what you see. Transient ST elevations cinema and is rest. So usually in the night or early morning and is cyclical, occurs at the same time every day. Response to nitrates, but in the long term, the treatment is better with calcium channel blockers. Right. Any questions about that?
Sir, about the previous question, invasive coronary angiography when compared to CT and like.
Oh, invasive coronary angiography කියන්නේ හස්ටි අර මේ the radial artery එක femoral artery එක පංච කළා ඩයි එකක් දාලා කරන එක ඒක. You send a catheter up to the heart and cannulate the coronary arteries and put a dye into it. That sort of invasive coronary angiography.
It's just an imaging technique, right? There's no
imaging, and if there is a block, they might put a stent in also. Depends on what they find. Yeah.
Okay.
Yeah. So it can be diagnostic as well as therapeutic. Ne?
Yeah. Okay. Thank you.
Yeah. So Nipun, yeah, stable angina, beta blockers are used as an anti-anginal. Depends on the symptoms whether you start a nitrate and a beta blocker at the same time. Most of the time what we do is start a beta blocker, nitrate as when required, sublingual, that sort of thing. But it all depends on how the patient does, what the symptoms are. Wage dewal. Hari? Good. Right. Now moving on, we have the acute coronary syndrome. So we are all talking about the chronic coronary syndromes. Ne? So now we move on to the acute coronary syndromes. Acute coronary syndromes. So acute coronary syndromes, as you know, and we have discussed this several times, can be divided into STEMI, based on the ECG changes, or unstable angina, non-STEMI, depending on their troponins. And currently we use high sensitivity troponin to make this diagnosis. So I'm sure all of you are familiar with this classification. Should be with 6 weeks to go for the exam. Right. True or false regarding unstable angina and non-STEMI? Chest pain occurs at rest is true, right? But remember, you can get acute coronary syndromes presenting with worsening exertional angina. Right? Worsening exertional angina as well. Right? So, in some people, say on Monday they can walk about 100 meters and they get the pain. Tuesday it's about 50. Then Thursday it's about 20. So worsening exertional angina can also indicate an acute coronary syndrome. Some people confusingly call that unstable angina as well, but that's not a right word to use. Right? Unstable angina is acute coronary syndrome. There have to be ST changes and troponin negativity. Right? What I like to call this is worsening exertional angina. That can also indicate an acute coronary syndrome. Anything, it might be a STEMI also. Right. So that is that. Second is wrong. Troponin levels are significant. Right. Now, in acute coronary syndromes, what reduces mortality? Obviously, whatever intervention you're doing, right, will reduce mortality. Definitive intervention. Right. Anticoagulation, thrombolysis. We don't do thrombolysis for unstable angina, non-STEMI. What we do is anticoagulation. Then we do, some people we do coronary angiograms, right? So what are the other drugs that improve their mortality? Antiplatelet statins improve mortality. Beta blockers, ACE inhibitors improve mortality. So in patients with acute coronary syndrome, the drugs that improve mortality are antiplatelet statin and also beta blocker, ACE inhibitor. Right. Right. So Nipun, unlike stable angina, in acute coronary syndrome, beta blockers do have a mortality benefit, right? So don't mix up the two. In stable angina, it is just purely for symptom control. But when it comes to acute coronary syndromes, they do have a mortality benefit, right? So beta blockers, ACE inhibitors, aspirin, statins, all of these have mortality benefit. Right. Okay. Hari. Now, the last statement is false. Reperfusion therapy with thrombolysis we don't do in unstable angina, non-stable. Now let me clarify something here. Now listen carefully. Now in unstable angina, non-STEMI, what do we do in Sri Lanka? Mostly we do medical management. Mostly we do medical management. we use anticoagulation with enoxaparin. That is the most common treatment that we do. But certain patients who have high risk unstable angina or non-STEMI, like this. This is again for your reference. So some people presenting with non-STEMI or unstable angina, they have high risk features like heart failure, arrhythmias, right? All of these. And there are some other scoring systems to assess risk. In these patients, an early coronary and invasive coronary angiogram is recommended. So patients with unstable angina, most of the time, medical management with anticoagulation. Enoxaparin is what we commonly use. And in this previous slide, I have given you all the sort of anticoagulant medications. This enoxaparin and or unfractionated heparin. Right? Some countries they use fondaparinux, which is a factor 10A inhibitor. Right? So that's a medical management. And of course, the antiplatelet drugs, aspirin, clopidogrel wagi. Right? And in your appointments, I told you about newer antiplatelet drugs like prasugrel, ticagrelor, all work like clopidogrel, very similar mechanism of action. So medical management is the mainstay, is the most commonly performed thing in unstable angina and non-STEMI. However, very important, in certain patients with high risk features like hemodynamic instability, patients who have arrhythmias, patients who have heart failure, right? Patients who have dynamic sort of ST, transient ST elevation, ST depression, those sort of people, right? Very high troponin levels, those sort of things, people will are indicated for early coronary angiogram, invasive coronary angiogram. Right. Any questions? So here I have also given you the timelines for troponin elevation and other cardiac biomarkers. Right. So question 5, any questions about
sir,
that?
Those high-risk patients you mentioned,
Oh, depending on what you find. So they go for angiogram. If there is a stentable thing, we stent. Some other you find that you can't stent it. Then we refer them for bypass and so on.
Either stent can't barrier, we don't go for this thrombolysis, no?
No. Thrombolysis is not given in non-STEMI syndromes. Nothing. It's only it's a treatment which is specific for STEMI. We don't use thrombolysis for anything else.
So now, say in a high-risk patient, you do an angiography.
Yeah.
There is a block, and you can't do PCI. You revert back to medical management.
Medical management, and probably refer the patient, depending on the coronary anatomy, for a bypass.
All right. Okay. Thank you.
Urakare stent barrier bypass karani. So there are all vessels are involved. Samara the atherosclerotic plaque is so long they can't fit a stent in or two. Samara tunak dalat they cover karaganna bad. They refer for bypass, and usually very early they do bypass in those sort of patients. Yeah. So Sasitu, PCI and invasive angiogram are not exactly the same. PCI can you do intervention. Percula's called intervention. Angiogram eka karala balano whether you can do the intervention. Right. So intervention is stenting. Right. So not all patients can be stented because of various technical reasons. Right. For example, when the 3 vessels involved, stent dan amaru. When there's a long lesion, stent dan bad, right? When it's right at the top in the left main wage, stent dan bad, but there are better ways of doing bypass, for example. Even, right? Okay, good. Right, now we go to ST elevation MI. Right, I'm sure this is, I have taught you this in the in the ward when we were doing acute medicine, right? So for STEMI, the MCQ වල මතක තියාගන්න කාරණා ටික මම ආයි මතක් කරනවා. STEMI reperfusion is the thing, most important thing. I taught you that reperfusion has to be done within 12 hours of symptom onset. Very important statement. Reperfusion needs to happen within 12 hours of symptom onset. Right? So 12 hours of symptom onset. That is important. There are two reperfusion strategies that we do. One is thrombolysis with tenecteplase. Sorry. And the other one is we use PCI, primary PCI. Right? So angiogram and stenting. Primary PCI. So these are your two options. Evidence will say that when you have all the facilities available, PCI is slightly better than thrombolysis. Right? So if all the facilities available, PCI is slightly better than thrombolysis. Right? But you have to have all the facilities available and all of that nonsense. Right? That is important. Hari. So let's go through this. We come back to that in a minute. So true or false regarding ST elevation MI, loading dose of aspirin is given after the diagnosis established by ECG. On clinical suspicion, you have to start the loading doses of antiplatelets. Very important. Again, aspirin clopidogrel is what we use. Right. Or if you have the newer ones, you can use the newer ones like ticagrelor. Bradycardia is commoner in patients with anterior STEMI when compared to inferior STEMI. Bradycardia is commoner in patients with anterior STEMI when compared to inferior STEMI. මතකයිනේ මේකේ කතන්දරේ නේද? මේකේ දවස්වල anatomy කරනකොටත් ඔයගොල්ලන්ට කියලා දෙන දෙයක්. Right? We teach you this during your anatomy classes as well. What you get is bradycardia and heart blocks are commoner with inferior STEMI. The reason for that is, in inferior STEMI, the culprit is the right coronary artery most of the time. Right? Right coronary artery is the problem. The right coronary artery supplies the conduction system as well. Right? So it is very common for you to have inferior STEMI and a conduction problem. Right? Because it's the right coronary artery that supplies the inferior part of the heart and the conduction system. Right? So you get heart blocks more commonly in patients with inferior STEMI. Okay. Like in non-STEMI unstable angina syndromes, aspirin or antiplatelets, statins, beta blockers, ACE inhibitors have a mortality benefit even in STEMI. Right? So, ඒක හරි. අපි කලින් කිව්වනේ beta blockers, ACE inhibitors, aspirin, statin, all of these have a mortality benefit in unstable angina, non-STEMI. Similarly, they have a benefit in STEMI as well. Right? That is a similar benefit. Right. Okay. And the last one, again, PCI is preferred to thrombolysis in all patients presenting with STEMI is not very good. Neither. I told you that there have been certain things. You have to have certain facilities available, right? So yes, so you can't say this like this as a blanket statement, right? There are lots of other factors that come into play. Take a better. Right. The fourth one, a new onset pansystolic murmur within 24 hours of presentation indicates septal perforation and VST. Right. Now, this is a very important concept to remember. There are certain late complications of MI. Right. The early complications. Early complications are arrhythmias, right? Early complication, arrhythmia. Another early complication is acute heart failure. The patients present with acute heart failure. It's an early complication. Some people get acute mitral regurgitation. Sometimes what happens is the mitral valve, it's held on by chordae tendineae, right? The mitral valve is held on by chordae tendineae. These rupture, giving rise to mitral regurgitation. So, that is acute mitral regurgitation. Later complications are perforation, wall perforations. Because ඒකට ටිකක් වෙලා යනවා. MI එක හැදිලා, then the wall sort of starts remodeling, thinning out. All these things take time. So these take several days. So wall perforations, right? VSDs, those sort of things takes time, right? And also they can get this, another delayed complication can be something called Dressler's syndrome, which is a sort of a pericarditis, immune-mediated sort of pericarditis that occurs a few days later. So, Metana, this statement is wrong because you can never have septal perforation VST within 24 hours of presentation. That is not possible, right? Septal perforation VST will take a little bit of time, 3 days, 5 days down the line. Okay. So here in this MCQ, we have talked about some complications of STEMI, and also some of them, we've gone through some of the management options. Any questions about that one? Right. Okay. Question number 7. Right. So question number 7, thrombolysis for STEMI is indicated in patients with chest pain and new onset left bundle branch block. So from your acute medicine classes, you will remember that new onset left bundle branch block in a setting of chest pain is a STEMI equivalent, right? So that is indicated. We now know that when it comes to thrombolysis, right, tenecteplase has much better outcomes compared to streptokinase. Much better outcomes. To tell a little bit more about that, the reperfusion rates are much better. Reperfusion rates are much better with tenecteplase, right, versus streptokinase. And also, the complications are less. There's less complications compared to streptokinase. Right. Thrombolysis should never be repeated. If you have a patient who has been thrombolized but continues to have chest pain, they should have a PCI, no doubt, right? You should never repeat thrombolysis. And I told you that, how do you know that thrombolysis has worked? කොහොමද මේක වැඩ කළා කියලා දැනගන්නේ? Right? කොහොමද මේක වැඩ කළා කියලා දැනගන්නේ? So patients' chest pain will improve, and you will also get these sort of reperfusion arrhythmias. Right? This is called accelerated idioventricular rhythm. Accelerated idioventricular rhythm. Right. And also, if you repeat the ECG, say 1 to 1.5 hours after the thrombolysis, you will have at least 50% reduction in the ST elevation. So if you repeat the ECG about 1 hour to 1.5 hours later, the ST elevations will have reduced in height by at least 50%. Right. And the last one you know is wrong. If you see Q waves, that is an absolute disaster. Q waves on the ECG indicate a transmural whole thickness infarct. So that is not good. Right. So this MCQ focuses on thrombolysis. Why I told you that PCI, when you take the trials, all the facilities available, PCI is slightly better than thrombolysis. But we talk about thrombolysis, we give you MCQs on thrombolysis because that is what we do in Sri Lanka. But PCI, we don't have facilities to do, right? And again, there is this another time window that we talk about, right? If you are at a PCI non-capable facility, which most of the places in Sri Lanka are, the maximum time you have to transfer and do the stent is 2 hours, right? From presenting to your hospital. Say you are at a district general hospital, somebody comes with a STEMI. You have to send the patient to, say, cardiology ward, Colombo, do the stent within 2 hours. Do the stent within 2 hours. That is almost next to impossible. So we don't even talk about PCI. So most of the MCQs are focusing on thrombolysis. But remember, PCI karanna ona velawal tiyena. For example, if the patient fails thrombolysis, you have to do a PCI. There is no question about it. Okay. Right. Unfortunately, I had to go now for something, but I think we have covered a lot. We can continue this from this point for Thursday. Hari? Thursday මම වෙලාවක් කියන්න සමත් ඔයාට අද හවසට. හරි?
Hari sir.
Hari. So, right. Any questions from the discussions we've had today? Generally?
Sir, if thrombolysis fails, rescue PCI යන්න පුළුවන් කොච්චර වෙලාවක්ද sir?
එහෙම වෙලාවක් නැහැ, earlier the better it is. There is no time, but earlier the better.
Okay, thank you.
Sir, in nuanced LBBs, in the ETU, we were taught about something called Gabosa criteria.
Oh, that is a bit of a difficult business. ඒක ඇත්තටම new onset LBB එක නෙවෙයි. If you are sorry, Vishal. If you are absolutely sure it's a new onset LBB, ඒක දාන්න අවශ්‍ය නැහැ. That's Gabosa criteria කියලා එකට කියන්නේ. That is mostly used when there is a pre-existing LBB and you want to see if there's ischemia on top of a pre-existing LBB. එතකොට තමයි ඒක පාවිච්චි කරන්නේ. හරි, but that's a very difficult thing to remember and we will not ask you that. Don't worry.
Does estrogen have a protective benefit on atherosclerosis?
Supposedly, it's a very controversial statement again, but we know that premenopausally, because of reproductive hormones, the incidence of ischemic heart disease in females is lower. But when they become postmenopausal, they rapidly catch up with males and probably increase, sometimes catch up and exceed the incidence in males as well. Yeah? හරිද ළමයි? So I hope this is useful. We will continue to do this. මම පොඩ්ඩක් මේක මේ slides ටිකයි මේකයි දාන්නම්. හරි? චමත්?
Hari sir.
හරි නේද? Right. I'll see you on Thursday. I'll let you know the time. Huh?
Okay sir. Thank you sir.
Okay.
Thank you, sir.
Thank you, sir.
Thank you, sir.